Welcome everyone, and thank you for joining one of our final webinars of Breaking the Silence Week. My name is Mark Orthius. I'm the President and CEO with the Mental Health Foundation. We've been really fortunate and blessed to have been part of this initiative this year with 5 other mental health organizations from across the province, as well as individuals with lived experience, subject matter experts, and organizations sharing information about resources, along with a lot of activity on social media, people sharing who they walk for, run for, bike for, rollerblade for, scooter for, and I saw, well, as my brother actually in Saskatoon, skateboard for. And so it's been really heartwarming to see the community kind of galvanize virtually during a time where I think mental health supports are more critical than ever. And so it's been really enjoyable from my perspective, and I'm really happy to have Suzanne here to share her experiences with you today. And I'll hand it over to you, Suzanne, and I'm gonna mute myself and turn my video off and let you take it away. So thanks for doing this, and we're really thrilled to have you part of this this week.
Thanks.
We can see that, so it looks good.
Okay, excellent. So I will just start by saying, hi, my name is Suzanne. My pronouns are she, her. I'd like to start this presentation by inviting you to take a few moments to reflect on where you first heard the term borderline personality disorder, what your current understanding and beliefs about this disorder are, and then I hope at the end you'll also reflect and see if anything has shifted or changed during this presentation. I'd also like to just mention that this is based on my own personal research and my own personal experience and is not academically reviewed at all. So let's begin. In 2016, I was diagnosed with BPD after struggling with mental health challenges since childhood. As a result, I was able to get the appropriate treatment and recover from the diagnosis. I have to admit that I first heard about borderline personality disorder in university after having been diagnosed with bipolar disorder. I silently wondered and was terrified that maybe this was a better diagnosis for me. Terrified because of the stigma that was attached to it. When I got this diagnosis, and more importantly, when I started working with individuals as a peer support worker, I saw the implication that this diagnosis has. So I was driven to learn more about it and so that I could better advocate for my clients and myself. BPD is especially complicated, so I will only be touching on broad concepts. So if you have any questions, feel free to use the chat and hopefully I'll be able to answer or provide more information at the end. Some people may know about BPD through TV and movies, Fatal Attraction, Single White Female. Not really the type of person you would want over for dinner or in your life, but these portrayals cherry pick and exaggerate symptoms for the sake of the story without thought or compassion for the individuals that have this disorder. We know it is important how and where the media portrays individuals, especially to those who have no experience of the disorder. However, we also have to realize that it's damaging to the individuals with the disorder, as it teaches us that we're dangerous, unlovable, and sometimes this internal stigma is some of the hardest stuff to get over. So when looking at the research, there tends to be agreement on 3 different themes for people with BPD that were manipulative, attention-seeking, and untreatable. In the studies, up to 89% of clinicians thought people with BPD were manipulative. The smaller words around those themes are actual quotes taken out of the research articles used by clinicians to describe individuals with BPD. I should mention that there are some limitations to these studies, as the majority of the participants were nurses, with very few community clinicians or psychiatrists involved. I was unable to find any studies using non-clinical population, but I think it's safe to assume that some of these themes would be found in the general population. We know that stigma translates into prejudice and discrimination, so it is concerning that professionals that are supposed to be supporting us have these negative attitudes and beliefs. It affects our care. This has real implications for the treatment of people with BPD. As participants in the studies, the nurses showed less empathy and optimism for those with BPD. Some research proposes that this can actually make symptoms worse, prolong treatment, and even go so far as to re-traumatize individuals. The discrimination is real. Some clinicians today refuse to treat individuals with BPD, and it can also be used as exclusionary criteria for some mental health or housing programs. So let's explore what BPD is and how it develops in order to understand why these labels are incorrect and harmful. Personality disorders overall are defined as someone who has difficulty in dealing with relationships and social situations, handling emotions and thoughts, understanding how or why their behavior is causing problems, and finds it hard to change to suit different situations. Knowing that, what is BPD? Broadly speaking, BPD is difficult with emotional regulation, impulse control, interpersonal relationship, and self-image. The way that I like to describe it to people is it's learned maladaptive thoughts and behaviors and a lack of skills to cope. So what are the criteria that makes up the diagnosis? First, I want to just touch a moment on traits versus disorder. We probably all have some of these traits, but it's only when it only becomes a disorder when it interferes with our daily functioning and quality of life. I mean, after all, who isn't afraid of abandonment? According to the DSM, so the Diagnostic Manual, you need 5 of the 9 criteria in order to get the diagnosis. So fear of abandonment. People with BPD are often terrified of being abandoned or left alone. Something as simple as a partner being late from work or spending time with other people can flare up this symptom. We may beg, cling, start fights, track loved ones' movements, or even physically block the person from leaving. Unfortunately, this behavior tends to have the opposite effect, driving others away. Unstable relationships. People with BPD tend to have relationships that are intense and short-lived. We can fall in love quickly and intensely, maybe believing that the new person will give us a sense of worth or self. Unfortunately, this is not how healthy self-worth works, and we become quickly disappointed when this doesn't happen. I've heard words like emotional whiplash as a result of the swings between idealization, love, and devaluation, hate. This is also known as splitting. It's like living in a world with no grays, all or nothing, good or bad, black and white. Unclear or shifting self-image. When you have BPD, your sense of self is typically unstable. Sometimes you may feel good about yourself, but other times you may hate yourself. Oftentimes we don't know what we want out of life, are frequently changing different aspects of our life. Kind of think of this as a social chameleon. Impulsive self-destructive behaviors. We may engage in harmful behaviors, especially when we're upset. We may impulsively spend money we don't have, binge eat, drive recklessly, shoplift, engage in risky sex, or overdo it with drugs or alcohol. These risky behaviors may help us feel better in the moment, but they often hurt us in the long run. So self-harm and suicidal behavior. Suicidal behavior includes thinking about suicide, making suicidal gestures, or actually carrying out the suicide attempt. Self-harm encompasses all other attempts to hurt ourselves without the suicidal intent. Common forms of self-harm include cutting and burning, but also substance use can be seen as a form of self-harm. Extreme emotional swings. Unstable emotions and mood swings are very common. One moment you may feel happy and the next despondent. Little things that other people are able to brush off can send us into an emotional tailspin. These mood swings are intense, but they also tend to pass more quickly than the emotional swings of depression or bipolar disorder, usually lasting minutes or hours or days. Chronic feelings of emptiness. So we often talk about feeling empty as if there's a hole or void inside us. At the extreme, we may say we feel nothing or that we're nobody. This feeling is pretty uncomfortable, so we try to fill the void with things like drugs, food, or sex, but nothing really seems to satisfy. Explosive anger. We may struggle with intense anger and have a short temper. We may also have trouble controlling ourselves once the fuse is lit, yelling, throwing things, or being completely consumed by rage. It is also important to note that this anger isn't always directed outwards. We can spend a lot of time feeling angry at ourselves, and this may be where that self-harm comes in. Feeling suspicious or out of touch with reality. We can struggle with paranoia or suspicious thoughts about others' motives. When under stress, we may even lose touch with reality, an experience known as dissociation. We may feel foggy, spaced out, lose track of time, or feel as if we're outside of our body, or in the case of derealization, that our environment is alien or surreal. Since people need 5 of the 9 criteria to get a diagnosis, this means that there's 256 different combinations in order to get the diagnosis. 2 people with the same diagnosis could actually only have 1 overlapping criteria. So it's important to remember that we're very different. Now that we have a definition, let's talk about some of the numbers and why it's critical that we understand and challenge the stigma around it. So the common number shown around the internet is that BPD affects 1.6% of the population. Some research notes it affects up to 6% of the population. I personally wonder about the 1.6, given what we know about stigma and people not seeking mental health services. The 6% may also be a more realistic number due to the fact that we know about 40% of BPD are originally misdiagnosed. It was traditionally thought that the prevalence was higher in women, with women making up to 75% of the diagnosis. However, we should consider that women are more likely to seek treatment, and that in our culture, women are seen as more emotional creatures, often considered hysterical, and BPD is about emotional regulation. So this could account for the tendency for professionals to diagnose more women with BPD. Conversely, the research has shown that men tend to get the diagnosis of PTSD, antisocial personality disorder, or major depression. So the research is actually beginning to reflect that it isn't so much a gender-specific disorder. And so of the 1.6%, 10% will die by suicide. This is 50 times the rate of the general population, and about 70% of us will attempt suicide or self-harm. It's important, it has also been reported that up to 80% of those with BPD have a history of trauma. Stats are great, but let's look at some concrete numbers. If we use Edmonton as a case study, we have just under 1.5 million Edmontonians. If we use the 1.6% population, just under 23,000 people would have it, and we would lose 2,288 people to this disease. Finally, individuals with BPD make up about 20% of the inpatient world, so those in the hospital, and 10% of outpatient work, so those in seeking community resources. So we take those numbers together, that's about 15% of the overall population accessing mental health services. Knowing that there are over 200 classifications of mental illness in the DSM, we can definitely, like, people with BPD definitely represent a good portion of those seeking services. This is why it is critical to start to challenge the stigma around BPD. We are common. It can be a life and death disorder, and our care providers have negative beliefs which affects our recovery. So through education, we can work to reduce the stigma. Marsha Linehan, the person who first came up with biosocial theory, shares that BPD is primarily a disorder of emotional dysregulation and emerges from transactions between individuals with biological vulnerabilities and specific environmental influences. So in other words, we have biological determined personality traits that are reacting to emotional stimulus. So we all have inborn traits. Think introvert versus extrovert. We're all somewhere on that spectrum. And our inborn traits organize how we approach the world, and they determine how we learn and act and our worldview. People with BPD are thought to be born with a high negative affectivity. Think more along the lines of anxious, neurotic, more of those negative anger, fear-based emotions, and have low levels of effortful control, which means we're more impulsive. Approximately 15 to 20% of individuals, like the general population, are considered to be born highly sensitive, physically and or emotionally. Just like some people are sensitive to smells or noise, some people have a sensitivity to emotions. This is actually not unique to humans. It is also found in the animal kingdom. BPD, if you have BPD, is 5 to 10 times more common with people who have first-degree relatives with the disorder. This is a bit complicated because nature versus nurture. If someone's living with someone who has mental health challenges, this might affect whether or not they develop it. But that said, we know from twin studies that 40 to 60% of BPD is predicted by genetic factors. It's important to note that it is not an inherited trait like eye color, but it can be developed given the right conditions. So putting these certain genetic vulnerabilities, those with certain genetic vulnerabilities at higher risk for developing the disorder. We're lucky now to have some studies which have done brain scans on individuals with BPD. From them, we can see that we have a different brain structure and function than those people without BPD, specifically in two main areas, the limbic system and the prefrontal cortex. The limbic system is made up of the amygdala, which is associated with the experience of emotions and formation and storage of memories associated with emotional events. People with BPD have amygdala that is noticeably smaller and may actually have undergone atrophy. The smaller the amygdala, the more active it is. This means people with BPD, when they have an emotion, they tend to feel it more intensely, and then that return to baseline or cooling down period takes longer. The hippocampus is associated with emotional reaction. It is the body's data processor. The hippocampus decides the correct emotional response of approach or avoid. So for people with BPD, the hippocampus is in a state of a constant state of hypoarousal. It consistently misinterprets threats and relays faulty information back to the amygdala. This means people with BPD are more likely to encounter other people and the world around them as threatening, when this might not be the intent or the reality. Going along with this idea are studies that show people with BPD have a hard time interpreting neutral faces and often see them as showing negative emotion. The hypothalamic pituitary adrenal axis is a complex name for three interconnected glands. It is primarily responsible for the body's production of cortisol. Cortisol is the natural chemical release during times of stress. Extreme stress, especially experienced in childhood and over a prolonged period of time, will lead to abnormal production of cortisol, which can be seen in people with BPD. The high production of high levels of cortisol affects stem cells, which can actually inhibit connections between the limbic system and the prefrontal cortex. And it can actually hardwire pathways between the amygdala and the hippocampus to predispose someone to be constantly in that fight or flight response. In short, BPD is associated with excessive activity in parts of the brain that control the experience and expression of emotion, especially in the limbic system, which deals with fear and anger. And so this may be related to that emotional instability. The prefrontal cortex, it affects our rationality and decision-making. It also kind of inhibits that more primal nature. People with BPD have prefrontal cortex that are inactive or inefficient. This may speak to the fact that impulsivity is a symptom. I'd also just like to note on trauma. About 80% of us have a history of trauma, and we know that trauma, like physical or psychological trauma, also changes the brain in much the same way that I've described with the brains of individuals with BPD. So it's hard to say if the trauma is what changes the brain to cause the development of the disorder, or if people are born with the brain exactly like this and trauma kind of amplifies it. We don't really know that. It's kind of a spectrum. But research shows that trauma puts individuals at risk for developing any mental illness and can affect a person's long-term physical health. If you're interested in this, learning more, I would suggest you look up something called ACE, Adverse Childhood Experiences, but I don't have enough time to go into that. So all of this together puts people with BPD with a predisposition to emotional vulnerability. What this means is that we have high negative affectivity as our baseline. We're very sensitive to emotional stimuli. Not only are we sensitive to it, we also have an intense response to that emotional stimuli, and it takes us much longer to return to baseline. I kind of like think of this as if you're born as a drag racing car, your gas and your steering are super sensitive. So any little turn or gas pedal, it means you're gonna like have a seriously big reaction, go super, super fast. However, you don't have access to the same brakes or a parachute like other people might. In short, we're expecting people with a compromised brain structure to function at the same level as the general population. If it wasn't enough, 96% of patients with BPD have a mood disorder during their lifetime, with lifetime depression being reported at 71 to 83%. When BPD is successfully treated, the other disorders often improve. However, the reverse isn't true. For example, you may successfully treat symptoms of depression and still struggle with BPD. It's like trying to treat the symptoms of the illness, but never addressing the illness itself. The social aspect of the theory is the experience of invalidation of our emotional states. Our emotional states are diminished. You are too sensitive, demeaned, you're being dramatic, or discounted. You're exaggerating. That's not true. The message is that we shouldn't feel the way that we feel, and there is something wrong with us for feeling how we feel. This teaches us to distrust and or disbelieve our emotional experience. We may also experience punishment for the expression of painful emotions, which intensifies that emotional response, ups the ante, which can lead to extreme emotions in order to be heard. This actually reinforces emotional escalation in order to get our needs met. It's the intermittent reinforcement which makes it so difficult to stop the learned coping mechanism. We learned that it doesn't always work, but maybe this time it will. Linehan talks about a few invalidating environments: the abusive home, pretty self-explanatory, the poor fit, so a sensitive child born into a family of very rational thinkers, the chaotic home, so parents that might have experienced an invalidating childhood themselves, who might have mental illness or addiction concerns, financially unstable, move a lot, have a lot of family conflicts, separation or loss of a caregiver, but also society. Invalidation doesn't only come from the home environment, it can come from school, sports, social media, and systematic oppression. You could have the most supportive caregivers, but if you're invalidated everywhere else, your experience and emotions questioned, you may be at risk for developing this disorder. So the sad part of this is that it becomes sort of a feedback loop where both feed into the other, making the situation worse. I'm biologically sensitive, my environment invalidates me, which increases my emotional response and actions in an environment that continues to invalidate me and just escalates more. So the outcome of both the social and the biological means that the individual doesn't learn to accurately label or trust their emotion, which can lead to an inability or lack of skills to regulate the emotions. If we're unable to label emotions and have an underactive prefrontal cortex, it becomes hard to problem solve emotional states, to avoid or self-soothe extreme emotion swings. If a person learns not to trust their internal experience, this can also affect their self-image. Individuals learn to search the environment for cues on how to think, feel, or act. People with BPD are hypervigilant, which means that we're always on the lookout for signs of rejection, or are extremely sensitive to emotional nuances, constantly checking the social environment for feedback. This can contribute to the feeling of emptiness and also to that lack of self-image. A person with emotional dysregulation can learn extreme ways of getting others to take them seriously. It goes with learning that ante up, that kind of like gotta ante it up, get people to listen. This can lead to that self-harm or suicide to express our agony. It can also lead to substance abuse to escape difficult emotions and to self-soothe. If a person can't trust their experience, it can lead to development of self-invalidation. I should be able to do this. What's wrong with me? However, there is hope. There are treatment options. There are a few ways to support recovery. Medication. Currently, there are no medications on the market that treat BPD. Medications help the symptoms of, say, depression, anxiety, or impulsivity, but not the root cause of the BPD. When BPD is successfully treated, the other disorders often improve, but the reverse isn't always true. Some therapies include CBT, cognitive behavioral therapy, which helps individuals identify distorted beliefs and thought patterns. Schema-focused therapy, which helps to reframe the way the person views themselves due to that poor sense of self. Mentalization-based treatment was designed for individuals with BPD. Mentalization is the ability to understand the mental state which underlies behavior. So it brings together aspects of psychodynamic, cognitive behavioral, systemic, and ecological approaches. The goal is to increase that mentalization capacity, which will improve affect regulation, reducing suicidality, self-harm, and strengthening the interpersonal relationships. Two therapies that I can speak directly about are psychodynamic therapy, which focuses on that unconscious process that manifests in a person's behavior. The goal of the psychodynamic therapy is self-awareness and understanding that influence on past and present behaviors. Psychodynamic group therapy gives people the ability to gain insight about their own behaviors by witnessing others engage in the same behavior. We're able to get feedback about behaviors in a safe, supportive environment. It gives a venue to try new skills. As with any therapy, it requires hard work and a lot of vulnerability and openness to getting feedback and look at what we contribute to a situation. Dialectical behavioral therapy, which was developed by Marsha Linehan, teaches skills of mindfulness, distress tolerance, emotional regulation, interpersonal effectiveness, and bridging the gap between the limbic system and the prefrontal cortex. If we think of BPD as lacking skills to navigate the world, then this is about learning new skills that may help be able to navigate the world a bit more easier. There is really good prognosis. 50 to 75% of symptoms will actually reduce in severity as a person gets older. Some symptoms may even resolve on their own. I think this is because we naturally learn more socially acceptable coping skills. However, treatment does really speed up this process. One longitudinal study showed that after 16 years, 99% of individuals were in remission, with remission being defined as 2 or more years without any significant symptoms. So let's circle back to the stigma. The really sad part about these stereotypes is that they become part of a self-fulfilling prophecy with accessing mental health services. Oftentimes, these behave from a place of trying to cope and find connection. However, this can lead to frustration and distancing from others, including mental health professionals, which then creates another invalidating situation, creating more behaviors. All of this feeds back into each other, creating a cycle that can actually re-traumatize individuals. So if I show up at the ER for a suicide attempt, I may just have confirmed the clinician's view that I'm attention-seeking and manipulative. The clinician distances and invalidates my pain. Because I'm hypervigilant, I'm going to pick up on this, creating more emotional distress, which heightens my emotions even more, and into this kind of tornado we go. So I hope you all agree with me that these labels are concerning. Now that we have a little bit more education about BPD, let's revisit them. Manipulation has a connotation of malice or some sort of sinister plot. The label manipulation makes it seem like we have some kind of control over our actions and that there's some sort of malicious intent behind them. However, our actions are really just desperate attempts to cope with extremely painful emotions. We're trying to meet needs, but we just don't have the skills to get our needs met anymore. We're using old skills we learned when young, facing extremely challenging or abusive situations that did in fact get our needs met then. However, now we're adults and we're out of those extreme environments, and it's like everyone else is speaking another language. We're inexperienced, but also resourceful because we're trying all different ways to get our needs met. It just happens that some of these ways aren't traditional or socially sanctioned methods, but we will get there. Marsha Linehan states suicide behavior is a response to unbearable suffering. These behaviors have become learned coping mechanisms for when we feel like there isn't any other ways left to cope with the emotional pain. It may be that we have no methods to express this emotional pain in a way that we understand ourselves. And it could also be a distraction from the high level of emotional stress. People with BPD experience emotions much more intensely and for longer periods than the general population. Our brains aren't wired the same. We don't have the same control over our actions. We're impulsive. When facing extreme pain, oftentimes an impulsive thought becomes an impulsive action when we often wish we could take back. We aren't so much attention seeking as we're seeking connection. We just don't know how to express this clearly. And we have learned growing up that they're in these chaotic environments to get our needs met with extremes. We don't have the understanding or language to articulate our need for connection yet. We don't know how to communicate our agony. We don't understand how to communicate our pain. And it's unfortunately that we do it in a way that doesn't support social bonds. I really like this quote I found from Dr. April Foreman. Your brain is screaming to have its needs met. It's screaming to be understood. It's screaming to be validated. So you start doing some pretty wacky shit in order to get the environment to respond to your brain. It's not untreatable. Remission and recovery is possible. Myself and people I know are proof of this. In the same way that people with depression cannot change their mood on a whim, individuals with BPD need time and space to learn new skills to support our recovery. I think it's important to remember that the behaviors are not the person. The behaviors are the disorder. Our actions are part of the symptomology. The hurt these actions can cause is a consequence of the symptom. I'm not trying to minimize or excuse the hurtful actions that myself or others have engaged in, but it is only through self-awareness and accepting responsibilities for past mistakes that I was able to change these maladaptive thoughts and behaviors. I had to learn the new language to communicate my needs, and this was a slow process, and it required a lot of trial and error. We know that changes to behaviors take time, especially with ones that we've been practicing for 10+ years. While these symptoms may represent themselves over and over, it can be frustrating. And I believe that this frustration comes from feelings of powerlessness and inadequacy to fix the problem from supporters, loved ones, and healthcare staff. A patient's self-harming can impact the healthcare professional's cognition. All my work is wasted. I'm a failure, which will then affect their behavior, the nurse or clinician withdraws, and thus reinforces the patient's negative belief about themselves. I'm a bad person. I deserve to be punished. However, there is hope because clinicians in the studies wanted to learn more skills to support individuals with BPD. And the studies showed that after training, empathy and optimism went up in the clinician. So after learning about BPD, you may have noticed that the term borderline personality disorder doesn't really tell us much about the disorder. It wasn't introduced until the DSM until 1980. However, we trace back the term borderline. It was first written about by Adolf Stern, who used it to describe patients that didn't quite fit neatly anywhere else. That said, the name isn't very descriptive, and perhaps that's part of the reason why it's so easy to forget that our behaviors are not always things we have the tools to control. The Treatment and Research Advancement National Association of Personality Disorder, so TARA-APD, campaigned unsuccessfully to change the name and designation of BPD in the DSM-5. However, borderline personality disorder still remains unchanged, and it wasn't moved from the personality disorder category to a trauma and stress-related classification. Currently, internationally, diagnosis is based on the International Classification of Diseases, so the ICD-10, and they don't have the term borderline personality disorder in there. They use the term emotionally unstable personality disorder. However, BPD is sometimes used. Some other suggestions for names that have been floating around are emotional regulation disorder, emotional dysregulation disorder, impulse disorder, interpersonal regulatory disorder, or complex PTSD. Complex PTSD is a bit of a controversy around that because, as mentioned before, only about 80% of us have a history of trauma. So research on BPD is strikingly sparse compared to other illnesses like schizophrenia and bipolar disorder. But as discussed, people with BPD represent a big portion of those accessing services. Taking a look at the brain and behaviors research funding, we can see that BPD is not getting research funding proportional to the prevalence. BPD is associated with tremendous emotional and financial burdens to individuals, families, and society. Because of this, we need more information about the disorder, more research dollars. So through education of ourselves and others, we can encourage the growth and compassion and start to understand the complexities of BPD. We can be allies and advocate for change. We know that allies are important for change within society. Big societal changes happen when allies stand up and back those experiencing the discrimination. We have to challenge these stereotypes when they arise. We know that what is thought as manipulative and attention-seeking behaviors come from a lack of language and skills to get these needs met. We know that to change behavior takes time, especially once we've been practicing for a long time. And while these symptoms may represent themselves over and over, and it can be frustrating, we know that we're not untreatable, and the research shows this now. It just takes time, many stumbles along the way. Myself, Noah, and my psychiatrist believe that I meet the diagnostic criteria for BPD today. I may still have some of these traits, but they'll no longer affect my daily functioning or my quality of life. We can advocate for change with our language choices. We know that language is powerful, and we can affect change by the words we use. One prime example of this is died by suicide rather than commit suicide. The term commit is from a time when it was a crime. We don't say, oh, they committed a heart attack. This is an important distinction because it's the disease that terminates the life, not the person. Finally, empathy and validation. My personal initial response when I hear about someone self-harm or suicidal intent is to validate the pain. How much pain must a person be going through to choose to hurt themselves or no longer want to live? I try to remember that I can't judge a person on the choices they make if I don't know all the options they had to choose from. I think this is an idea that we can remember when interacting with all humans. So let's start being the change we want to see. Basically, spread kindness like glitter. And these are my resources. And that's it.
Thank you so much for that. That was an unbelievable presentation, and so many takeaways for me. And there's a couple questions here that maybe I'll ask of you. But I hadn't heard that. I'd heard, I mean, died by suicide. The commit a heart attack, I think, is something I've never heard that before, but it's something I'm definitely going to use going forward because that's so germane to making somebody understand the nuance of language. So I'll just ask a couple questions. I'm not sure if you can see them. So a question is, what is one thing you are proud of that helped you move forward while living with BPD?
Oh, well, that's a good question. I think the thing I'm proud of is the amount of work that I have put into recovery. I don't think I would be where I am without having put that work there. It was definitely hard at times, but I think that just goes to the fact that people with BPD are very persistent. We are able to find a lot of ways to get our needs met, and I just have been extremely lucky to be able to access the resources that I have. Yeah, so I guess that's, I'm also, I think I'm also proud of the work that my whole family has done. So I am extremely lucky in that my parents have validated my experience, and we've all worked together. And I know that that's not the case for a lot of people who struggle with mental health challenges, because they still have to deal with a family of origin that might still be invalidating or just unwilling to work with the individual to try and heal all of those wounds.
Thank you. There's a question about somebody wanting to learn more about adverse childhood experiences, and if there's a resource that you would recommend.
I would just Google it. There is a lot of information. There are studies that prove basically that people with these, like, depending on the number of ACEs, like it's a questionnaire and you go through and you kind of score yourself. And the more you have, the more it affects like your, how long you'll live, essentially. People who have a lot on that scale end up dying sooner, unfortunately.
And there's a comment, and I was going to just mention the Palix Foundation because they've done a lot of work with ACEs and also the Brain Story certification. And I guess the question is, have you done the Brain Story certification through the Palix Foundation is the funder, and their organization, I'm blanking on the name. I'll look it up right now. But are you familiar with that, Suzanne?
No.
Okay, let me just, anyways. While I'm looking this up, maybe I'll just ask another question of you that I'm curious about. So you're, maybe just speak to what you're doing now as a peer support worker to the broader group.
So as a peer support worker, Alberta Health Services has started to bring in peer support workers on the addiction and mental health side. And we are individuals with lived experience of mental health and or addictions. And we are supporting other individuals who are either newly coming into the system or who have been part of the system, and sort of just walking beside them while they're working towards their own path of recovery. I'm trying to think. So that's kind of what I do. I'm extremely lucky to have kind of like stumbled upon this position, and it's really rewarding to get to work with individuals and really like champion for and root for them. They do all of the work. I do none of the work. I'm just kind of there to witness the magic that they do, and kind of also break down some of those barriers between the power dynamics with clinicians and patients. So we actually don't use the term, within peer support, we don't use the term clients or patients. We use the term participants because again, language is super important. And these people are participants in their own recovery journey. And I don't think that we should diminish that at all.
Thank you. And I asked that just to set up my next question, which is a personal question for me. And I had included, and I see that another panelist or another participants included some links to both Brain Story certification and ACEs, which is through the Alberta Family Wellness organization that's been funded by the Palix Foundation. So that's in your webinar chat right now. And yes, this will be available, this recording will be available on the Breaking the Silence website and also on the Mental Health Foundation YouTube once we get it edited and up and going, because Sam in my office will have to cut out all of my blabbing as she's done many times before. But I guess my question now is, you know, the healthcare system slowly evolving to include individuals with lived experience as part of a more holistic model of care. How do you see that continuing to evolve over time? Because just listening to your presentation, I've listened now to, and I've listened to I've had a lot of conversations with peer support workers and individuals with lived experience, but I was struck by not only your lived experience, but now your understanding of brain science and you know you prefaced your presentation with the fact that you don't have a PhD in whatever, but that being said, I did listen to a guy on Monday with a PhD in whatever, and it was everything you said was almost exactly the same as what he said. So I can validate that from that perspective. So I thought it was fascinating that we're now seeing individuals with lived experience marry that with a nuanced understanding of the brain, which is really fascinating. And so I guess I'm now just talking, but somebody was asking what kind of qualifications and education do you need to have as a peer with lived experience? And maybe so answer that, and also where you see the peer support movement going and how clinicians are coping with it, I guess I would say, because there's probably a way to frame it.
So to become a peer support worker, the beautiful thing about that is you need no education. The only qualification is that you do have that lived experience. That's within Edmonton peer support. I know that there are other positions, I believe in Calgary, where they have like a peer school that you then go through with CMHA, and then that leads into positions within Alberta Health Services. But currently in Edmonton, you don't need any qualifications other than that lived experience. And we have various different positions in different departments, portfolios. So lived experience can sometimes be matched to what people have experienced. So people going with the housing programs, having experienced homelessness might be a better match for that.
That's really cool.
And then how I see it moving forward within AHS, I think we need a lot more positions. We don't have a lot of positions. I think there's over 20 at this point within Alberta Health Services in the Edmonton zone, which is awesome. And there are definitely times that are challenging with some teams that don't understand peer support yet. Because one thing that I've heard from clinicians is, what do you bring to the table that I don't? I have my own lived experience. And to that, my response is, there's that power dynamic, right? Like, you're coming to this meeting or whatever with a title. You're coming with the idea that this person is a client. And a lot of professions you can't disclose, right? It's in the ethics. It's not appropriate to disclose. I know some clinicians who do at times. And so peer support can really be that, like, the way I like to describe it is the greeter. Like, we're the person who's like, hey, welcome. Like, we can have some of those conversations about really that self-determination of the individual and help them advocate for what they want their recovery to look like. We also can bring a really great perspective to care conferences, because if you haven't lived through something, I think it's, again, like that privilege thing that we're all talking about now in the greater world. A lot of times we're blind to the privilege that we have. And if you're a clinician who doesn't have any lived experience, you may be blind to some of the situations that people with lived experience have actually gone through. So we're getting there. It's like, culture change is slow. And I think we're moving there.
Fantastic answer. And I think Edmonton's really leading the way in the province and potentially the country. And I totally agree with you about, I mean, transformational change is hard. And so I think clinicians and people that are used to doing things a certain way for a long period of time are either threatened by, or I think maybe insecure about their own role as a psychiatrist or nurse. And I don't want to paint a broad brush. And so I think over time, as peer support work is validated by the participants, and a new generation of clinicians come online, that's when there'll be a marriage that is more harmonious. Not to say it's not now. Sorry, there's a lot more questions, so I'll stop talking about my own particular. Any suggestions for people struggling with this diagnosis to find resources or support they need if they are not connected?
I think the first place is to get connected. There is a DBT program. It does have a long wait list. The full program, which is a year, like, to do the full DBT therapy is a year. But AHS does have kind of packets for like emotional regulation or distress tolerance that they're able to offer. So yeah, I think the first step is to get connected and then look at those resources, but also do some research on your own on what therapy you think would be a good match for you, because it's not about what the therapist thinks you should do. It's also about what you can do, right? And I can't speak highly enough of the day treatment program at the U of A hospital and the Grey Nuns psychiatric outpatient program. They're very intensive, more psychodynamic programs, but they were very instrumental in jump-starting that recovery journey.
Okay, hold on. Lots of dialogue here. Are you or anyone providing peer support for AHS staff?
I think naturally. I don't think any of them are like.
It's implicit.
It's built within the system. So definitely I have, and other peers have, that inside view. We're able to see what some clinicians are struggling with on their own, and we can offer some of that support, but also we model what recovery looks like. We model that idea that self-care is so important to our own mental health. And by being there and modeling this, and we model this also for the participants we work for, we're able to kind of like naturally kind of be like, okay, this is what you can do to support your wellness. And then people oftentimes pick up on that and they're like, oh yeah, I should really concentrate on that self-care.
That's great. And there's a comment that Edmonton does have has peer support training, but people take it after they're hired at this point. Maybe just speak.
Yes.
Yeah, yeah. And so is that training? And again, I can't. Sorry, are you at Access 24/7? Is that where you're?
I was there for a short period, and then I came back to Young Adult Services.
Okay.
I apparently like to skip around a lot, which has a really great added benefit that I get to work with a lot of different diverse demographics. So just recently, I was in with Young Adult Services in a housing program, and now I've been moved over to Access Open Minds within Young Adult Services. So that's the walk-in clinic for young adults.
Yeah. Okay. Great. Our foundation's been pretty active with Access 24/7 and Access Open Minds, and are huge.
Yeah.
So that's wonderful. Lots of just positive comments about how great your presentation was, and lots of love for the peer support movement. No more questions, I don't think. I will just add one more editorial that I think I've done. I don't know how many webinars I've done this week, but I'm really critical on PowerPoint decks generally, but you had, and I'm not criticizing others, that is the best PowerPoint deck I've seen in years in terms of just what did you have? WTF brain?
I actually edited out a bunch of the swears.
Oh yeah.
I personally like swear a lot. I had a dad in construction when I was little, so like I said, modeling, he taught me a lot of really colorful language. I also feel like sometimes people need that jarring, and as a peer support worker, I have the ability to do that. And I think it brings a sense of humor, right? Like some people, when they see how I dress or present myself, they're a little like that I have a bunch of tattoos. Like I've had clinicians say like, you do not, it doesn't match with how you present. Right. On to my PowerPoint presentation, I actually, my undergrad is, I did a double major in psychology and art and design.
Oh, wow.
I'm almost completed. It's taken me a long time because of my my mental health. I started in 2002, and this year I'll be finishing my final 3 courses. So I guess that's what I'm proud of, is that I'm going to be able to do it eventually. So I don't think anyone should feel like just because they're unwell now or they have been unwell for a long period, that is the state of things, that there's always the ability to change.
Well, thank you for sharing all this information and being really a leader in mental health. I don't know if peers or people with lived experience understand how transformational they are and will be to the system and helping people, people's lives, and help people not die by suicide, not commit a heart attack. And so thank you for your leadership and advocacy and talking to us today. It was really, really, really interesting.
Thank you.
Have a good day, everyone. I'm going to shut this down.
Sounds good. Thank you.
Take care. Bye.